Yes, sir. We can start.
Sure, start.
Right. So, good evening, everyone. It's a pleasure to begin the E-Gurukul series again with our renowned teacher, revered by all the students, Dr. P C Mahapatra. He is a teacher par excellence, we all know that. And with this new series, uh, we are having the first lecture in the form of changing trends in obstetrics and gynecology practice, key to be successful gynecologist, solving the clinical dilemmas. So without any further delay, I hand it over to Dr. P C Mahapatra.
Thank you. Thank you, Dr. Diwan and the whole team of Team Juventus for again the E-Gurukul series, second series, and after a gap of about a couple of months, we have started way back in 2020, September 5th, and finished about the 28 episodes on a theme of surgical skill transfer. Well, you are responsible for again reviving this and continuation of the E-Gurukul series 2 and focusing on a very important topic on solving clinical dilemmas. So I welcome everybody and all the viewers for again stimulating me to continue these educational activities, and thanks Juventus for again propagating the education amongst our fellow gynecologists. I welcome all the viewers and my colleagues, my senior, my junior, my students, grand students for this particular continuation of the academic activities. I bring greetings from the place of Lord Jagannath again, and today I again welcome you to this series 2 of E-Gurukul, a Juventus initiative, and the theme is solving clinical dilemmas in obstetrics and gynecology. When the episode 1, I thought I will start with the first episode with a very important understanding of yourself and our subject, the obstetrics and gynecology. And this is a very dynamic science where over years, over decades, we have a changing trends in our practice of obstetrics and gynecology. Even with the 4.5 decades of experience of mine, I have seen a sea change. What I was doing in way back in 1970s and 80s, and when I look forward in 2022-23, there is a sea change in the practice. Maybe the research, maybe the growth and evolution, the concept-wise changes, and the technology has led us to this particular change. So my topic today episode is a topic concerning this changing trends in obstetrics and gynecological practice, and the second component, a key to be a successful professional. Well, I don't know whether I'm a successful man or a failure man, but both I have got, and therefore I must share with all of you youngsters, and you can improvise, you can do much better than me over 4.5 decades of an experience as an obstetrician for that. And the second component, I will tell some tips about it. Well, obstetrics and gynecology, I love it. I'm proud of my subject. In fact, I am not finding a person who is responsible for nomenclature of this beautiful word, tricks of obstetrics and logi of gynecology. It's so befitting. The obstetrics, the tricks of obstetrics and logi of gynecology, the art of obstetrics and the science of gynecology. Hats off to the man who has really coined the very important term and terminology called obstetrics and gynecology. Now coming to the evolution. The evolution of women's health, the beginning is a midwifery practice. Diseases of reproductive organs came later on, and gynecology was coined for that. And when the amalgamation of two different areas in women's health, born the specialty obstetrics and gynecology. I can remind you that in the curriculum, in the degree and credentialing, we have got MS or MD in obstetrics and gynecology in various colleges and universities. I can quote one of my teachers. Her degree was MO, Master in Obstetrics, at that time when gynecology was not incorporated into it. Long before the amalgamation of obstetrics and gynecology, we have reached a change in the degree itself. The great function of women's life has for years made her the subject of specialists, male and female, the obstetricians. The subsidiary relations of her special organs and the special requirements of her physique based upon these have necessitated the establishment of another class of specialist, the gynecologist. Way back in 11th edition of Till in Obstetric Gynecology has told this. Well, the medical fraternity, the medical fraternity, when we consider, we are all classified as a physician, surgeon and gynecologist. Believe me, we have the same concept of alleviating the sufferings, but the temperament is different. The temperament of a physician, he has thinks that he has two brains. With two brains he can think and think anything and win the world by thinking only. Whereas the surgeon, they think that we have got two hands. Our two hands can do anything in the world. But we obstetricians and gynecologists, we have got two fingers. We claim that the whole universe rests with our two fingers. Now the change with the two fingers is now for the last so many years, it has changed from two fingers to the transvaginal probe and telescope, replacing all these for that. And therefore, this is a lot of change in the medical fraternity over the years for that. We gynecologists are a separate class, believe it or not, usually by choice, not by chance. We usually enter into this profession by choice, not by chance. We are a strong believer of destiny because there are two truths in life, birth and death. And there is no other truth other than the birth and death. And we are fortunate enough to see the truth of life at the same time. Baby is born, mother is dead. I think these are something unique to the faculty of obstetricians and gynecologists. And in many cases, science doesn't claim or science doesn't prove the death or suffering of that. And therefore, we are strong believer of destiny. Many cases we do not know why she has died, why this has happened. So therefore, we are strong believer of destiny. We are mainly by labor, not by luck. And the correct definition of luck is labor under correct knowledge. We live for others, don't live for ourselves. And we balance personal and professional life. I hats off to my lady gynecologist, those who really balance and professional and personal life and be successful in both. It is very easy to tell, but difficult to practice. Hats off to them. Individually, we are very strong and powerful, but collectively, very weak and timid, and we are a tunnel vision personality for that. These are again hard facts. 3/4 of the life spent for profession and don't understand the meaning of life. We are bound to be exploited from everybody, a professional hazard. Highest ranking in society, but unsocial. Don't think of future, only lives in present. We are a real amalgamation of head, heart and hand. There are professions where they utilize their head. There are professions where they utilize their hand. But we are that category of professional. We amalgamate head, heart and hand. And that's why we are unique. We are unique in a combination of art, science and commerce. All follow us. And last but not the least, we don't have any religion. We have a humanism is our religion for that. Now, obstetricians and gynecologists, are they different? Certainly they are different. You introspect yourself. Over decades of practice, all of you must realize that we have a human touch. We are humanity. Touch is there. We are more tolerant. We are more accommodative. We accommodate everything. Nobody accommodates us, but we accommodate to the pediatrician. We accommodate to the anesthetist. We accommodate to the pathologist. We accommodate to the staff. We accommodate to the patient. And patience is our main thing for that. Patience, I believe that gynecologist has a lot of patience. I believe that patience pays and patient also pays. We have got a special senses. Touch, vision and hearing are unique, are superb in comparison to the other profession. We have a control over biological functions, sleep, bowel and bladder. And majority of us have a high level of energy. 24/7 they are active. Coping emergency drills. We are supreme in stress and time management, but very, very poor in finance management. We are satisfied with little, unlike other faculties, and that's why we are exploited by all sources. And we very often come in news, and most often amidst mob violence and medical legal entity for that. Now let's have a change in medical profession, a close look from healthcare to medical care. We don't see as a human being as a whole, as a holistic approach. We target for a medical care whatever the problem comes. From disease to diagnosis, we deal the diagnosis. And most peculiar, from social identity to disease identity. All of you must have realized this. When you're hospital, the social identity is lost as soon as she enters into the hospital. She is recognized as bed number 9 or cabin number 10 or a case of PIH or a case of fibroid. The disease identity is more important than the social identity, which forget that. From generalist to specialist and super specialist, as the different subspecialty of obstetrics and gynecology has grown up and evolved over the past few decades. From healing to treating, from clinical sense to technological dependence, and from rational use to irrational abuse, from faith to court, from pleasure to pain, from charity to business. And that's why it needs a serious introspection. And lastly, from we concept to I concept. It should be we concept rather than I concept. I means illness, we means wellness, and that should be changed for that. Now, over the past decades, we have got sea changes in the development of the subspecialty in the field of obstetrics and gynecology. There is a need of the people, there is a need of the diseases, and there is a need of the provider. And therefore, we have evolved into different subspecialties like high risk obstetrics, Fetal medicine is a different entity. Maternal-fetal medicine, there are separate entity for which the whole life is spent by somebody with this fetal medicine. Adolescent gynecology, reproductive medicine has for the last few decades has grown up like anything. Gynec endoscopy has emerged and a very important tool in the field of gynecological surgery. Sonography in obstetrics and gynecology, again a very important part. Urogynecology or female urology, neonatology, gynecological oncology, critical care in obstetrics and gynecology, menopausal health, sexual health, so on and so forth. It is a very varied subspecialty and practice of the obstetrics and gynecology, either a generalist or a different subspecialty depending on your choice. So what are the changing trends? The changing trends, let me divide into different sections. Subject. Our subject has got a change. Obstetrics and gynecology subject has a changing concept. There are various changing concepts in the different field. Anything you pick up in any subject, there is a changing concept during the past few years. Evolving technology. Technology has evolved. Improved skill. The skill of the surgeons is very well improved as time passes by. And teaching and training. Also there is a changing trends. When we were students, our teachers were teaching and training us is completely different now. Because the teaching and training module has been changed. I think more attention has to be given as technology has improved on simulation practices. Evidence-based medicine has been a part and parcel of our practice because this should be provided with some evidence, some guidelines, some protocols, and some recommendations should be there, and therefore we are abide by the evidence-based medicine. But not only evidence-based medicine or experience-based medicine was there previously. Now evidence-based medicine is the way forward for that. Coming to the second important part is the patient profile. The patient profile is also changed over years. Now the educational status of the patient is varying. The knowledge and aptitude and the change in the concerned patient awareness of the different diseases, the concern about the Google doctors, these are all on the patient profile. There is a change in that. So therefore, while practicing that, the patient profile is also important for that. A common gynecologist treating an illiterate patient and a very VVIP, there is a completely different change and changing trends in practice for that. System profile, wherever you are, many people, some from the private practice, from an individual to group, to the corporate hospital, to government setup, you have to have a system profile for that. And that system is also evolving a great change over the few years. And you have to be accommodative and acclimatized and adopt to the system for that practice for that. Provider profile, we are the provider. And the provider profile has also a changing trends. The pattern of work, the thinking and the attitude and aptitude of the provider has changed almost varying from decades to decades, and that's a very important part for that. Now, in medical schools, we have read many things, but we have not read in medical schools in many things for that. Let me say one thing. Over years, we have evolved this, that we have not anything about the communication skills, which is very important now in the practice of obstetrics and gynecology. And due to this bad communication, at times we face many problems for that. A good communication skill has to be taught in the medical schools. Interpersonal relationship, because you alone cannot do it. It's a teamwork in many cases. You have to enter the practice with the teamwork. So interpersonal relationship is important. How to build up that? Organizational and leadership ability. You may head an organization, you may head a big hospital or an organization. So you must acquire some capability as a leader for that. Your attitude and aptitude development should be there for that. And last but not the least, you are not simply a professional. You are a human being. You have a work as well as a life also. So therefore, many times you're dedicated to work itself so that you compromise your life. And life and work balance is a very important part for that. And it will take an hour together to speak about this particular aspect of life and work. And life and work balance should be there if at all you want to be a successful professional. And last and very important part in medical schools we do not being taught is the management. The different types of management which is needed subsequently during practice. The man management, the stress management, because we're full with stress 24/7. Time management, because we're really do a lot of work in the same time, and time management. Finance management, which are very poor. Finance management we should have it. And if you have a hospital, although the managers are there, the hospital management you should know something about it. And last but not least, the crisis management. The emergency management and the crisis management is important. These are some of the components now the syllabus should include it there in the curriculum for that. Now coming to the obstetric practice, what are the different changes we notice over here and the changing trends? Now obstetric practice, once the pregnancy is diagnosed, the obstetrics practice started. This was the concept long before, but not now. The pre-conception counseling has emerged as a very important part in the obstetric practice, which is called a prenatal care. Pre-conception counseling is very, very important in many aspects, and some of the cases a shattered motherhood or a pregnancy loss, or before pregnancy if there is something they want to clarify, they want to be very clear that whether there is a defect or a pre-existing defect, whether I'm a fetal suitable for carrying out a pregnancy or not. These could be very well dealt with the communication counseling in the before pregnancy comes for them. And therefore, this is a very important area where the practice also revolves around. Now coming to the antenatal care. Antenatal care has a sea change. And gone are the days where the antenatal care, the concept was only weight, BP measurement, urine albumin, power abdomen, the uterine size, and the fetal heart. The fetal compartment is at that time was very difficult to rule out for that. There is no gadgets in that. The gadgets are improving. The concept is increasing. Therefore, there is a lot of change. The beginning of NC, antenatal care, when she comes first as a clinical, as a practitioner, we should find out whether it's a normal pregnancy or an abnormal pregnancy. What are the antecedent history which is affecting this? And prevention and prediction of abnormality, if at all we find it. This should be thought up and planned at the beginning of ANC, and this is very well required for the healthcare provider for that. Now, diagnosis of pregnancy. When we were students, we were being taught that there are three evidences of pregnancy: presumptive evidence, probable evidence, and a positive evidence. Now with the gadgets available, we are almost forgetting about the presumptive evidence and the probable evidence. The positive evidence of pregnancy is possible with the gadgets available for that. So no more classical symptomatology of early pregnancy. Sonography invaluable tool in early pregnancy, and no more, we are almost obsolete. At that time, we are being taught of by uterine size, Palmer sign, Hager sign, Jackmer sign, internal ballotment, external ballotment. These are all obsolete now when sonography has become a very invaluable tool in early pregnancy for that. Pitfalls in pelvic examination in early pregnancy, diagnosis of that in early pregnancy, that uterus is soft, uterus is 8 weeks, uterus is bulky. It is just a guesswork for that. The definitive diagnosis has been really by the sonography, and this is very important. Sonography is a part and parcel of all obstetrics for that. And believe me, the knowledge of sonography, without the knowledge of sonography, an obstetrician is incomplete. Without the knowledge of endoscopy, a gynecologist is incomplete for that. So this is very, very invaluable now. Then second important aspect is a screening. The aneuploidy screening is routinely being performed now in pregnancy. Gone are the days when the concept was that the aneuploidy screening is necessary in elderly people. As age advances beyond 35-40, the incidence of the aneuploidy is more, and the diagnosis of the genetic abnormality like the Down syndrome is much more. Now the concept is changed. It can be found in younger age group. So aneuploidy screening has been really a part of the antenatal care for that. And biochemical screening tests like double marker, quadruple marker, pentamarker has become a routine procedure in all pregnancy, because of now we want a healthy mother with a healthy baby, and therefore this is important that even with one or two children, the quality of the baby should be very well done. And if it is possible to detect it before pregnancy, we can prevent a lot of subsequent mental retardation and the spastics for that. Now, genetic screening has become incorporated here when the concept of the non-invasive tests and finding out the fetal DNA in the maternal blood. The cell-free DNA in the maternal blood is a very important innovation in the research, and therefore NIPT, non-invasive prenatal tests or non-invasive prenatal screening is a part and parcel of pregnancy in all pregnancy. Now there is a controversy about it, and my feeling is that my message would be that I give more importance to the genetic screening. All this biochemical screening tests with or without the biophysical NT or 11 to 13 week scan was being done by everybody for that. But this is a screening test, and the accuracy of the genetic screening, like on non-invasive, is almost equal to amniocentesis for that. I'm almost varying 99 to 100% sensitive for that. And therefore, I believe that because of the cost effectiveness in practice in India, we were not able to do it. But I think now my proposition is that as the new innovations of the genetic lab is growing, the need is growing, the volume is growing, they can reduce the price, and we can do that. For the last 1 year, I'm almost doing all cases NIPS, not NIPT. We don't want to screen all the genes. NIPS is important. I started doing the NIPT for 1,000 cases, out of which 18 cases were positive for either 13, 18, and 21, and one case per sex chromosome. The rest, I didn't find a single case with the other genetic disorders have come out. Therefore, I requested, I want these three so that the cost can be reduced, and they reduced the cost to almost around 3.5 to 4,000 rupees. With that, they're doing the NIPS 13, 18, 21, and sex chromosome. This is all I wanted that, and therefore, maybe in future it will be a routine procedure, and NIPS will done in all pregnancy, and only for the pre-eclampsia screening we can do a PLGF for that. Now, important is 11 to 13 week scan. There is a lot of significance for that. There's also a change when the sonography came and obstetric sonography evolved. I've seen the evolution of obstetric sonography, where we are teaching that if at all sonography is essential, one scan during pregnancy is necessary. That is an anomaly scan during 18 to 20 weeks. Now, anomaly scan is 18 to 20 weeks. At that time was recommended. Then there is a reverse of the pyramid for that. And therefore, as we go more into the fetal compartment, as we have evolved the subspecialty of fetal medicine and maternal fetal medicine, we are convinced that not single scan is necessary. A serial scan during the pregnancy can be very important for the perinatal outcome. And therefore, the reverse pyramid, 11 to 13 week scan, has a lot of significance. 11 to 13 week scans, the Fetal Medicine Foundation has evolved that yes, more importance from that time, you can diagnose many of the genetic diseases like these 13, 18, and 21 chromosomes. And particularly, the NT has become the universal procedure for all obstetricians across the globe. 11 to 13 week scan have a different, apart from the NT scan, it has also components of the gestational age accuracy. The accuracy of the gestational age can be very well determined 11 to 13 week scan. That is the number one. The NT scan can find out for the aneuploidy screening, very important, and the early manifestations, the congenital malformation, particularly the anencephaly. Not all these cases. the anencephaly can be diagnosed as a much earlier thing for that. So 11 to 13 week scan has become a part and parcel of all pregnancy along with the anomaly scan or TIFA. Now coming to the baseline investigation. The spectrum of baseline investigations has also changed. Earlier, the routine investigations, we restrict into the hemoglobin, ABO-RH, and then subsequently the VDRL. These are all and the urine albumin. These are all the basic in line of investigations. Now, the protocol has been expanded to the fasting blood sugar. The routine thyroid screening is important parameter that we adopted. VDRL and torch were not giving very importance to, unless it is a selective cases, no more to torch, no more to VDRL. Only in selected cases when the history suggests you can do it for that. And HbA1c and the HIV. These are all part and parcel in improvement and addition to the spectrum of the original baseline investigations for that. Now medication. We know that first trimester is a very vulnerable period as far as the growth of the conceptus is going on, and the teratogenesis is related for that. So we want to affect the teratogens, and one of the very important teratogens is some of the medications for that, and therefore we don't write any medications during the first trimester, and particularly from 7th to 9th week of gestation. It's very vital for that. This is a very crucial period where teratogenicity is related to that. And the only medication we do it now evolve is initially we are using the folic acid, and pre-conceptional folic acid continuing during the time of pregnancy is usually adopted for prevention of neural tube defects. There are a lot of evidence for that addition of folic acid 5 mg. We were giving this 5 mg folic acid, but later on the science and evidence shows that folic acid is not the only thing for prevention of the open neural tube defects or the 9 months, 9 challenges. There are additional things which revolves around the concept of homocysteine metabolism. Hyperhomocystinemia is related to 9 months and 9 challenges, where the homocysteine metabolism deals and the steps of homocysteine metabolism, 2 steps and 3 particular things are required for that. The 2 steps of the conversion of homocysteine metabolism is, one is a folic acid, another is the methylcobalamin, and third is a pyridoxine. 3 things are responsible for that, and therefore it is a routine practice now to have a combination of these 3 in right proportion and right dose for that, and then avoiding all the medicines for that during the time of first trimester. In fact, because of the vomiting, because of the early morning sickness and all that, we are avoiding the other medicines like iron, calcium, which are usually giving it. More so, the requirement is not there in the first trimester, and therefore this is resolved for second trimester onwards for that. So the message which I give it, that the medication accepting this particular thing of combination of folic acid, methylcobalamin and the pyridoxine, this is given. There are some gimmicks where they're adding the DHA for that, but I think it's no justification because the brain development doesn't occur so early for that. That's so. And the use and abuse of other drugs, accepting the vomiting antiemetic, particularly the doxylamine preparations, which is being safe during the first trimester pregnancy. The use of hormones has become predominant now. Then the spectrum of the hormones like progesterone in all pregnancy is now an abuse rather than a use. But there is a change in the use of progesterone for that. And counseling. Very important is a counseling on this part, right from the first trimester, because the patient is conscious and he is educated and she needs a counseling. Always think that yes, pregnancy, you should welcome pregnancy. Patient is very happy. At the same time, she is very nervous. She's feeling very, at that time, many of the patients are very apprehensive about that. But this is why counseling from our side is important. That pregnancy, consider pregnancy is a normal physiology and a normal health. And therefore, There are some agencies which have come out, the spiritual organizations of Garbha Sanskar. They gave a concept on Garbha Sanskar for that. And you stimulate the patient, you counsel and have a positive attitude to that pregnancy for that. This is very, very important apart from medications for that. An attitude change has to be done for that. And this will have a positive attitude to the motherhood. There are some do's and don'ts and number of small things, what is to be done, what is to be not to be done, whether travel, whether sex, whether the food, this food or that food. There are a lot of myths and realities, and these do's and don'ts you advise for them. And many cases in first trimester pregnancy, when they come, they want a termination of pregnancy. And gone are the days where the termination of pregnancy by surgical methods of doing a suction evacuation for that. Now there is a great shifting to medical than surgical, and the surgical risks are there, and this is a change in the concept of the change of medical abortions has left a great deal for that. We have innovative molecule for that which are designed for the last couple of 3 decades or so. We are very happy with this medical abortions for that. Coming to the second trimester. Second trimester is an era where only the clinical accuracy could be there in second trimester. Importance of accuracy of clinical examination. Clinical examination regarding the size of the uterus, the fetal heart, and estimations, clinical estimate of the fetus of the different presentation position. Of course, it is not relevant in second trimester and third trimester, but the overall the fetal dimensions, fetal size, and the Liker volume, all clinical accuracy would be there in the second trimester for that. Not in first trimester, we are not doing, where sonography has taken over, and in third trimester is absolutely variation up to 3 to 4 weeks. So second trimester, importance of accuracy of clinical examination. Apart from it, the GDM screening has become routine in second trimester for that. And therefore, the one-step glucose test, like glucose challenge test, and by DIPSC criteria of 75 gram 2 hour post glucose. GDM screening is a mandatory for all pregnancy now. There's no doubt about it. And of course, the anomaly scan. The second trimester anomaly scan is a very important parameter in addition to the 11 to 13 week scan. The second scan after 11 to 13 week scan is an anomaly scan for them. Anomaly scan 18 to 20 or 22 weeks is the optimum time where we do it. When the termination era or termination is legal age has increased, therefore we have expanded the anomaly scan little bit 2 weeks later for that. So the anomaly scan is a very important, a fetal and all fetal medicine specialists, they are very profound and experienced in anomaly scan for that. There are levels of scan. The general gynecologist and obstetricians can do an initial scan for that, and they should learn sonography to do an anomaly scan for that. If there is any doubt, they can refer to the fetal medicine specialist for an anomaly scan. This is very, very important because we can see with the resolution of the machines has improved, the man has improved, and the knowledge has improved. The majority of the anomalies can be diagnosed. Even the triple anomalies can be easily diagnosed with that. In addition to these anomaly scans, you can expand more. You can do a subsequent scan later around 20 to 24 weeks about the fetal echo. Fetal echo is an additional thing in addition to the anomaly scan for that. So this is mainly the taken up of by the fetal medicine people for that. Biochemical screening test like a quadruple marker scan, preeclampsia screening like a PLGF or a pentamarker scan can be an addition in the second trimester for that. And in the second trimester, all throughout pregnancy, you must give a counseling regarding the nutrition, regarding the medication. Regarding the medication in second trimester, the two things from time immemorial, the prescription of iron is important, calcium is important. Why? Because we know that the physiology of pregnancy needs an additional 800 to 1000 milligram of additional iron, in which 6 to 8 milligram of iron is daily required during the second trimester and third trimester. And therefore, the medication iron routinely in all cases for them. There was a study in some of the European countries, whether iron is required, prophylactic iron is required or not. They have correlated with the ferritin estimation. The ferritin, if it is less than 70 micromole, I think these are the cases where iron supplementation is necessary, whereas more than 70 micromole, they did not need an iron supplementation for that. But in our country, we know the prevalence of anemia, the prevalence of iron deficiency state, even if the hemoglobin is normal, they are deficient in the tissue iron. And the total requirement of 800, 1000 milligram. For that, we have to continue this iron throughout the pregnancy from second trimester onwards for that. And calcium supplementation, protein supplementation, these are all essential medications. And depending on the individual cases, you can add some medicines. Say GTM, you can give an insulin or the drugs for that. If some other things like a cardiac disease, some other things like a medical disorders of pregnancy is there, you can add some medications in that particular situation for them. Now, termination of pregnancy again, we have forgotten the intrahepatic saline, we have forgotten the extrahepatic saline, extrahepatic Emcridil and all that. And now it's more switch over from medical to surgical terminacy. We have almost abandoned hysterotomy. Earlier, I have gone through that phase. I have experienced everything. Now the changing state is that the more of medical than surgical. We have potent drugs available for stimulation of the uterus. We have potent drugs available for cervical priming for that. And therefore, this particular case of termination of pregnancy in second trimester, if at all it is warranted, particularly if there is a congenital malformation of the fetus and major malformation of the fetus needing a termination, or there is a severe oligoamnias due to leaking, these are the cases where we can do medical methods for that. Third trimester, again the clinical inaccuracy is there. The variation is from 3 to 4 weeks for that. Even with interpersonal, intrapersonal, same thing, there is a variation of the clinical inaccuracy of the size of the uterus. And therefore, we require the interval growth scan. The sonography is a part and parcel. 11 to 13 weeks we done it. We have done with the anomaly scan. We have done with the fetal echo. And then subsequently, the interval growth scan is necessary to monitor the growth profile and identify the fetal growth restriction for that. And believe me, this is a very important part if you want to avoid a stillbirth or this intrauterine fetal death. There's a very beautiful evidence in that the stillbirth occurs, the growth of the fetus or the affection of the fetus, the stillbirth after 34 weeks, it is more common, and before 20 weeks is more common. From 20 to 34 weeks, at least majority of the pregnancy go uneventful for that. But basically, we need to evaluate the growth pattern of the fetus and diagnosis of the fetal growth restriction. Therefore, in addition to that, biophysical profile or a modified biophysical profile has been adopted, and sonography with or without color Doppler can be of great help to this particular case. And then third trimester, the medical disorders complicating pregnancy. There are various medical disorders complicating pregnancy which needs an attention, and the hypertension, the preeclampsia, the liver disease or the jaundice during pregnancy, the pruritus during pregnancy, the asthma, the cardiac diseases, all these autoimmune diseases, these are all medical disorders complicating pregnancy are of immense help to that. Then during the third trimester, the role of antepartum fetal monitoring. There are gadgets available for antepartum fetal monitoring where the fetal growth restriction is there. We have diagnosed it by sonography, but the functioning part we can do it by the antepartum fetal monitoring with the different electronic fetal gadgets which is available for that. And prediction and prevention of preterm birth is very important in third trimester. And prediction and prevention of preterm birth by noticing the cervical length by sonography can be aided for that, or a diagnosis about the threatened preterm birth, we can predict it and prevent it by different agencies with the drugs. The innovative molecule has been there. The atoshiban is an innovative molecule where the oxytocin antagonist has become a really unique agent for prevention of the preterm birth for that. You do it, you just administer during the threatened preterm birth, and that will give a very important, that will broad the cycle and continue it for that. So this is a very important molecule which has come up for that. Now coming to the labor, very critical. The labor is a decision for vaginal delivery or a cesarean delivery. Now the cesarean delivery, it is a global concern of increasing of cesarean birth, and there could be some valid reasons, and should be increased. The WHO and the government, state government, national government, WHO, everybody is concerned about it. Even our organization is concerned about the increase of cesarean section. There should be a critical review. There are various criteria, including the Robson's criteria, which has come out with that, how to reduce the incidence of cesarean section for that. There are some reasons about it. Say, for example, the medical legal is an important part. The practice of defensive obstetrics is an important part. The cesarean section on demand is an important part for that. If the patient wants that, I will do a cesarean section for that. And this is a very important challenge to the obstetricians for that, to decide for vaginal delivery or a cesarean delivery for that. So decision for vaginal delivery and cesarean delivery is important. There are some technical reasons where there are multiple variables which is there. At times the obstetricians fails to decide whether go for vaginal delivery or a cesarean delivery for that. We have expanded into the fetal compartment in sonography. In the different monitoring methods we have expanded, but still we want a sensor. I want that with the electronic era, in the computerized era, I think a different agency should come out, a multiple sensor should come out, where the sensor will automatically tell what is the life of the baby. The baby sensor tells that yes, my life is 6 hours, my life is 48 hours, my life is 1 week, and the decision would have been much more easier for that. The human brain cannot capture that. So therefore, there is a place now evolving research on artificial intelligence, and artificial intelligence is going a research for that. They will decide decision for vaginal delivery, which case has to be done for vaginal delivery, and which case the cesarean has to be done for that. The artificial intelligence, but it needs the data. Unless the data and machine learning cannot do it, AI cannot grow for that. But I think in future it will be very simple for that when AI has become very pronounced for that. Institutional delivery. Institutional delivery is a very paramount importance in a country like India, when we are seeing a very significant maternal deaths. I think the only thing which has reduced the maternal death is institutional delivery. If institutional delivery is there, this is the main reason for which now you see the scenario of India all over the country, excepting few states, how they have reduced the maternal deaths. The only thing is institutional delivery, and delivery by the skilled personnel, either midwifery or obstetricians, delivering in a special institution where every facility of dealing with the emergency should be there, and therefore you can tackle the near miss deaths for that also, and morbidity can be very well. Painless labor. Now educated people, they don't want to have a pain, and we have got painless labor for that. Earlier, we had to reach the pains of analgesics and obstetric analgesia, various components were being taught for that. Now, painless labor. Epidural, when it started, epidural has become proved as one of the very efficient painless labor for that. But somehow it has not become propagated in each corner of the country, because there are various reasons for that. The anesthetist is required for that. We are lacking depth of anesthetist in the painless. In accepting, in few instances, in some of the hospitals dedicated for the labor shoot, and particularly for some of the big hospitals or a corporate hospital and a very defined center where a painless labor with the assistance of the anesthetist, they can do a epidural. And it has become a required procedure for that, and we in India are not lagging behind the Western countries for that. Still, it is being practiced in some places for that. Intrapartum sonography, yes, it has become a research one day, and about 1 decade since the research, nowadays it has come up in a big way to help in the process of monitoring the labor for that intrapartum sonography, but it has a way forward for that. Intrapartum fetal monitoring. We have got very gadgets for fetal tocodynamometry in relation to the uterine contractions. The different patterns of the fetal monitoring will be done by intrapartum for that. And when it used it, There is a variations of the sensitivity and specificity, and majority of the report says that yes, unnecessary and cesarean section is more important for that. So this is because the human brain and the monitor are not able to capture that, and it has been proved that the AI support, the artificial intelligence can very well clarify and this human error, and therefore AI support intrapartum fertility monitoring is a way forward and advances in the near future for that. Instrumental delivery, infect a lost art. The destructive operations, no more destructive operations such things for the various reasons, and now the instrumental delivery, either the vacuum or the forceps or the odor device. These are the only three which is left behind. We are forgetting about the instrumental delivery, other instrumental delivery. But still, it is being practiced for that. And selective cases, we do it for that. It's not a lost art, but we are the degree in which the instrumental delivery was used. I think that is a sea change during the last 2 decades to 3 decades. Episiotomy, there is a lot of controversy regarding episiotomy, and now it has been really proved beyond doubt, and evidence is so that restricted episiotomy is to be done for a rational use for that. Unnecessary episiotomy in all cases is not advisable, and that's evidence also showing for that. Prophylaxis and management of PPH, the hemorrhagic deaths are profound for that. If you see the maternal mortality, the PPH was amount in the list number 1 case for this. And therefore, aggressive management and prevention of PPH has been there, starting from the prophylaxis by WHO, the active management of the 3rd stage. There are different protocols which have been adopted and routinely used for that. And of course, the management of PPH, the hectic intervention, once PPH starts, the very good ecbolics which have been devised over years for that, and the living ligature, in addition to the diagnosis of the traumatic PPH and management, and various other innovative procedures of the uterine tamponade or the uterine suction device, with the aggressive management of the shock, with the blood transfusion availability facilities available. Management of PPH has become very important method. There's an innovative molecule which has come out and method which is there for that. And prophylaxis and management of PPH. Now for the last 2 years, we have an innovative molecule for prophylaxis, the carbitocin, which is, I think it has to be very much emphasized and to be routinely used in all cases, because it is superior to the conventional oxytocin. Oxytocin for our induction of labor and augmentation of labor, and for prophylaxis, I think carbitocin is the first drug of choice for that. And if there is a PPH, the innovative, the different hectic intervention which I have told, and this has to be adopted. And lastly, the baby, for the baby, the NICU. We are seeing cases where the NICU facilities are required for some of the cases when you deliver a baby of FGR, fetal growth restriction, or a preterm baby, or some adversities occurring during the time of labor affecting the fetus. I think the NICU should be a routine part in all cases of obstetric unit, and not only the NICU, the quality NICU is essential for that. The quality in terms of the personnel, in terms of the equipments, and in terms of the place, it should be there if at all you want to improve the perinatal survival improvement. Now, coming to the operative delivery. The instrumental delivery, I have already told the status, the 3 forceps, low forceps, not high forceps. Gone are the era of high forceps or mid forceps. Only low forceps is acceptable for that. Vacuum is acceptable for that. And now, replacing the vacuum is an Odin device. Replacing the vacuum and forceps is an Odin device. It is still not very popular, not used routinely, but it is a procedure which will come in the future for that. When coming to the cesarean delivery, again I have emphasized the need for reduction of the cesarean rate. The primary cesarean section rate would be reduced, and unnecessary cesarean, you introspect and evaluate and have an audit, cesarean audit, where you do a unnecessary cesarean section, and there you can do a need for reduction. There is no doubt about it, but I don't agree with the target of 15% or 20% like that. It depends on the place. In a referral place, in a tertiary center, it's not equal to the primary center for that. In a private hospital, government hospital, public hospital, I think there's a variation, and therefore the need for reduction of the cesarean section rate is acceptable for that, but there should not be any target for that. But if at all the cesarean has been done, cesarean now has become safe in view of the skill, in view of the good anesthesia, safer anesthesia, and facilities of blood transfusion and antibiotics facilities for that. So cesarean has become very safe now, and safe cesarean, as far as the techniques of cesarean is concerned, there is a lot of changing trends and changing techniques. These are all some debates for that, and therefore the Miska-Bladdock technique, when it came, as really it has propounded the single layer suture, single layer closure of the uterus with the avoidance of the peritoneal closure, had become really catch up for that. Now evidence shows that this Miska-Bladdock with a single layer, there is a debate regarding the single layer versus double layer. The integrity of the scar, the subsequent problem of the morbid adhesion of the scar, the CS nick, and subsequently the CS scar pregnancy, all these are related to the bad techniques for that. So single layer closure versus double layer closure. Evidence now is in favor of double layer closure for that. And this is a changing trends in there. Even for sutures, there is a changing trends. We use a small, I think the volume of the suture should be less. Gone are the days when you are using the sutures, catgut was being used. Number 1 or number 2 catguts was being used for that. No more catguts, because the various newer tissue-friendly sutures are available. The vehicle has become very good, but the number is important. We have reduced from number 1 to number 0 catgut, because the volume of the suture metal is important. If the volume of the suture metal inside the uterus or myometrium is less, the scar integrity is very good for that. And therefore, the changing techniques are there for that. Many people have adopted that, and the skill, I fully agree that the skill of the new train should be there. The next generation is improving, and that therefore safe cesarean section should be our motto. Whatever you do it for the safety of the patient, not to show your surgical excellence, that you are completing the surgery within 15 minutes. Don't compromise with the time. Don't do the surgery and seek the watch for that. Changing trends, changing techniques. And lastly, I will say that surgical planning should be there for that. You don't at the same time decide what to do and what not to do. Before any case, you find out what are the problems I'm getting. Suppose a case of previous 2 cesarean, suppose a case of placental morbid adhesion. You must prepare yourself before what to do and what not to do. What problem you will anticipate there? If there is a placenta previa, anterior, posterior, central, what is to be done? If there is a transverse line, how you deliver the baby is important for that. And delivering the baby is a very important part where you avoid unnecessary traumatic PPH for that. So there are debates which have been solved, and for the benefit of the patient, safe cesarean is our motto for that. Now, concomitant procedures. The concomitant procedures, yesterday's contraindications are today's indications. There is again a change, particularly in relevance to the cesarean myomectomy. Gone are the days when I'm telling that when there is a myomectomy during cesarean is next to 2 months later, and therefore don't do it, keep it there. And therefore now with the newer techniques available, the improved surgical skill available, cesarean myomectomy has become a routine procedure. And my personal experience of cesarean myomectomy, I always in favor of doing a cesarean myomectomy, particularly the large intramural myoma. I do a separate technique. I want to propagate this particular technique for that, the intracavitary myomectomy or subendometrial myomectomy. You don't have to apply a different, another second line incision for that. Through the uterus, you can do it for that. Now coming to the gynecology. The gynecology has also seen a changing trends, changing concepts, understanding reproductive endocrinology. We didn't know anything about reproductive endocrinology about 3-4 decades before. It is really a changing concept. Concepts are changing in gynecology in various aspects for that. Expanding horizon of imaging sciences, and this is very, very important. Sonography initially, the sonography, I've gone through the phase of sonography. When TVS came, I think TVS has become part and parcel of everything for that. Even in reproductive endocrinology and medicine, reproductive medicine in infertility, you see the Louisa Brown when it was done by the IVF, and first IVF, it was done an ovum pickup by laparoscopy. Then laparoscopy has a lot of disadvantage for that. So TBS has evolved as not only in diagnostic but particularly in part and parcel in infertility management, starting from follicular study to ovum pickup. This is very important. And the diagnosis of uterine and adnexal lesion by transvaginal sonography is absolutely very essential for that. It cannot have that, though it has limitations in unmarried girls, though it has limitations in some cases where the patient is not very comfortable. Otherwise, TBS has got lot of information dealing with that. Sonography expanding horizon of imaging sciences. Color Doppler, CT, MRI, all these are important. CD. Color Doppler, you see the iota classification for that to identify the malignant tumor at next cell tumors. Color Doppler has become very essential tool for that. CT MRI has become an expanding tool for the lesions where the limits of the lesions are very well accurately diagnosed for that. MRI spreading of the endometrial carcinoma, say for example, or carcinoma cervix, the extent of the lesion can be very well examined. And when we are doing a surgery also, the topography and the planning and programming can be done by good sonography and MRI mapping for that also. So the mapping of these bioimaging sciences is a very important tool before surgery for that. And therefore, where expanded horizons of imaging sciences has helped us in many cases, now to such an extent that it is incorporated. It is many cases of the cases which was earlier done by the endoscopy is now switched over to the sonography. Say, for example, for the diagnosis of the Mullerian anomalies, the only thing was by hysteroscopy. And now it has been replaced by 3D scan, 3D sonography, and MRI. 100% accuracy can be there. So with the non-invasive methods, when we are doing it, why go for an invasive methods of that? So this is a really a change in the pattern of how sonography has evolved and the imaging science has taken over for that. Minimal invasive surgery. The growth of minimal invasive surgery has almost 80% of the gynecological ailments can be dealt with the minimal invasive surgery. The hysteroscopy and laparoscopy. The evolution of the hysteroscopy and laparoscopy for last more than 30 years in the country and the globe has really changed the situation in the diagnosis as well as the therapy for that. More for therapy for that. Because there are many cases where diagnosis has been taken over, shifted to the sonography. But therapy is a major thing in minimal invasive surgery. There are a lot of advantages I did not mention. You all know about the merits of the minimal invasive surgery, and therefore the hysteroscopy and laparoscopy has become part and parcel of gynecologists and treating the diseases, and particularly from benign to malignant, and from uterine to extrauterine to emergency to elective to, in many cases, minimal invasive surgery. Now non-invasive surgery, I level non-invasive surgery as a vaginal surgery for that. So vaginal surgery seems to be a no-hole surgery and a non-invasive surgery for that. And starting from the prolapse, starting from the genital prolapse to the different female urological diseases, the hysterectomy, particularly the non-descent vaginal hysterectomy, which was being done by the laparoscopic surgeon. I think if it is possible, if it is feasible, vaginal delivery, laparoscopy should be contained. And therefore, the vaginal part, vaginal hysterectomy, has become really a boon for the patient and surgeon also. And therefore, it has evolved quite big about non-invasive surgery. And this is mainly the vaginal hysterectomy and the laparoscopic hysterectomy are aimed how to reduce the incidence of the abdominal hysterectomy, which is a morbid procedure for that. And therefore, the battle is over that minimal invasive surgery and non-invasive surgery has to grow and more. But there is an abuse of this. Try to have restrict the abuse. There is no dogma in science. Wherever indicated, individualize the judgment and individualize the procedure. But this is in fact a growing concern and really a change in the concept of the surgical innovations for that. Power in surgery. I have seen the power in surgery like when we started with the cautery, simple cautery, I think a heat cotter was there. Electrosurgical device was a new innovations and a very important part in all surgical armamentarium. I think the power in surgery is a very important part for that. In the beginning, we used to suture it, each layer by layer, small bits of vessels we used to suture it. Now it's very easy. Electrosurgical device has transformed itself from monopolar to bipolar to vessel sealer and to shear. I think these are very innovative procedures. And vessel sealer, when it came out, I think sutureless surgery has become really routine procedures now for the last couple of, I think, 1.5 decades up to 2 decades. We are using it, electrosurgical device, and particularly for the bipolar sealing vessels for that. And harmonic scalpel is certainly an advantageous thing for a laparoscopic surgeon. And this is a very uniform, this is a different concept than electrosurgical device. This deals with the ultrasound energy instead of electrical energy for that. Laser has become a very important part in the power of surgery. Laser not only start from the laser precision surgery is done by laser surgery, and it is at least the electrosurgical device and laser and harmonic are complementary to each other for that also. And this is very important. Laser has now come over to a different, the rejuvenation of the vaginal surgery, vagina in the new subject which has come out in a laser has also been used for that. ABC organ beam coagulator for a superficial oozing, I think just spray it and just the bleeding is more. There's something an innovation in the power in surgery for that. Shifting from surgical to medical management for that. Again, gynecology. Initially, those cases were subjected to surgery, now shifting to medical management. And these are the medical managements of newer molecules which have come up, for which the medical management has taken over it. Say, for example, the common example I'm telling you that for endometriosis, medical management is now taking over the surgical management, starting from the GnRH analog to the Gynecologist. These are very important. Same thing with a myoma, instead of a myomectomy to a ulipristol is a medical management for that. And I hope the research will produce more of medical managements and innovative molecules so that the surgery will be really less and less and medical management will be more and more. And in surgery, we have got an innovative surgery. As we go, innovative surgery, particularly for the deep and infiltrative endometriosis, the bowel resections and other things, they are very important thing. For urological surgery, the urological, I think, diversion, particularly the ureteric anastomosis or diversion to the bladder or ureteric ureteroanastomosis. These are some innovative surgery which has been taken over, and we think that some of the newer aspect will come in future for that. So newer molecules, coming to the newer molecules in obstetrics and gynecology. I will say a few things about the newer molecules for that. I've already told about the first newer molecule about atosyban. Oxytocin antagonist, atosyban has become really a revolution in the field of preterm labor and assisted reproduction for that. It has been used, the spectrum of the use is important, and not only there is a lot of newer dosage schedule which have adopted in atosyban to see the cost of the patient and cost effectiveness. We have really reduced an ultra short and a short dose rather than the standard dose of preterm labor of using the 9 vials for that also. And therefore, atosyban I have already told, I need not repeat here also. But it should be a very good molecule which has really kept help in a case where the threatened preterm labor. I think the ultra short is a very important thing. And cases where it is established preterm labor, it can delay the pregnancy to a variable days to months. And for the transfer of the patient to the higher center, for NICU facilities, or for the corticosteroid which influences the maturity of the fetal lungs, this has really been approved. And last but not least, it has infiltrated into the fertility practices. And in fertility practice, particularly the embryo transfer, we give an atosyban during the peri-embryo transfer period of 3 hours, and 1 vial is enough for that, so that the result of pregnancy, continuation, and IVF results will be much more for that. Apart from the atosyban, the parental iron has a status. Now, what is the status of parental iron? The iron, oral iron for time immemorial, it has been there for decades. Now it has switched to parental iron, and lot of pharmaceutical companies are aiming for parental iron for that. The parental iron preparations now available. Iron sucrose has started this the second generation of parental iron, which has come up, iron sucrose. But iron sucrose has been used extensively and still being used extensively. But it has some little serious side effects also, and the side effects for the men. Then the newer safety drug, the FCM, the ferric carboxymaltose has come out. If you compare the side effects, I've done studies where the 6% side effects with iron sucrose, whereas 0.6% with ferric carboxymaltose for that. And therefore, the ferric carboxymaltose has become almost replaced the iron sucrose for that. Not only about the safety, but the efficacy and the single dose of about 1000 to 1500 milligram at a time can be given without any toxic results for that. And this has become a very unique particularly for prophylaxis as well as for therapy, starting from adolescent to pregnancy to postpartum to perioperative use. And this has become a part and parcel, and more emphasis has been given to this parental iron for that. And ferric carboxymaltose, and now the other iron preparations, people are going for that. And this is very important that non-dextrin preparation are available for that, and the non-dextrin preparation are coming in a big way for that. There are some ferromoxitol is another injectable iron preparations which is to be really very well used in European countries for that. It has not come to India, but these ferric carboxymaltose, iron sucrose has become very popular in the country, which is very, very effective for that also. And then the progestogens. One of the controversial area, it's not a new molecules in gynecology, but it has a propagated, and progestogens has become a unique thing in pregnancy when it's there. Micronized progesterone and dihydrogesterone, 6-dehydrotestosterone. There has been a lot of upsurge of dihydrogesterone since the last 1 or 2 years for that. And I must tell that there should be more of abuse is there and more of misuse is there about the progestogens in pregnancy for that. There is some use for that also wherever is indicated. Say for example, in recurrent pregnancy loss, recurrent miscarriage, or there is a subchorionic hematoma, or it is a IVF pregnancy or IUI where the luteal support is mandatory. There is no debate about it. But this is not a drug to be routinely used as soon as the UPT is positive for that. But micronized progesterone and dihydrogesterone has become really a unique. And dihydrogesterone, by a lot of studies have shown that it can be used for IVF only. Earlier it was only restricted to the RPL and luteal phase defect. But the Lotus 1 and Lotus 2 studies have shown that micronized progesterone versus dihydrogesterone, almost a non-inferiority trial, proved that dihydrogesterone can be effectively used, particularly during the IVF luteal phase support for that. And apart from it, the Dynogest has become a molecule which has proved one of the very good molecule in a case of endometriosis. I think for the last 1 decade or so, Dynogest has become a market and people used it for that. The Dynogest, the pain relief particularly is unique. Pain relief could be there, but the two things people think that it can enhance the fertility or augment the fertility and reduce the structural lesion. The mass will be diminished. That those two things are not there. But the Dynogest is a very good drug for pain relief for that. Ulipristol for my uterus. Ulipristol is another new molecule which was used and temporarily banned and not being used because of the liver affections for that. Now again it has been proved that ulipristol can be of use particularly for myoma, for a medical management of myoma rather than for surgery. Gonadotropins. See, the people practicing fertility or the general gynecologists writing gonadotropins for the ovulation induction. It is a from evolution to revolution. It has gone through many stages for that revolution, from the conventional HMG to the FSH and follicular stimulating hormone pure FSH, then purified FSH, the urinary FSH, to the recombinant FSH, and now we are waiting for the newer drugs like the colifertin the dose advantage, the weekly we can give it for that, and something oral for these innovations that can come out for that. And we are seeing in the near future the newer drugs can be there for that. Contraception, the new generation of OC pill has come out, the combination of estrogen and progesterone. Progesterone, of course, the Gynecologist combination along with the estrogenic component has become a very useful contraception. There are many advantages of it also. And we are expecting the change in the estrogen component also when E3 will come and E2 will come. I think that will replace combination of E3 with the progesterone or Gynecologist can be a third generation oral contraceptive for that. There are many advantages of this particular contraception, newer contraception, mainly for the side effects for them. Prostaglandins, we evolved from prostaglandin E2 to PGF2 alpha and misoprostol. We think the misoprostol is a unique contribution of a medical or a molecule in obstetrics and gynecology because it has a wide range of activity. I have told about this misoprostol. It started with the pregnancy, medical abortions or medical termination of pregnancy. Then it's evolved the cervical dilator and many aspects of the mid-trimester pregnancy, or even with the IUFD in the late pregnancy also, misoprostol can be used. And last but not the least, very good thing for the prophylaxis of PPH, maintenance of PPH. In all delivery, the rectal administration of 600 to 800 milligram of misoprostol is a unique thing, and the results are very good for that. So prostaglandins has really used in obstetrics and gynecology in many aspects for that, and this is certainly a newer molecule for that. And about carbitocin, I've already told the WHO champion trial, I was associated with it, and I can firmly say that this carbitocin, which was done, the trial was done in 2014, but it's come out in 2021, 7 years after. The dose, I think the carbitocin 100 microgram single dose is enough and superior to the recommendation by WHO, the active management of third stage of labor of oxytocin, 10 units to the IM and 10 units to the drip. Carbitocin is very important as a prophylaxis and an ideal ecbolic in the present status for that. And there are various research molecules, other research molecules which are yet to come. I think I'm very optimistic that there are some research molecules which will come out in obstetrics and gynecology which can really serve the purpose of this conventional thing for that. Say, for example, I think I was proposing a dream, I think fantastic, the fanatic idea came to me about the endometriotic powder. Endometriosis, you sprinkle that molecule in the powder in a grate for endometriosis, and after 3 months you find that they absolutely uterus ovary, no need of dissection and surgery is required for that. Some research molecules could be there for myoma, some research molecules could be there for many gynecological ailments for that, and that will come out in coming forward for the coming few days for that and coming months. And there are some gray areas where it is necessary for that. The gray areas of finding of that, particularly in the case of obesity, anti-obesity molecule we wanted. As in many cases, this is really a problem for the adolescent, for the reproduction, for everything for that. So gray areas of the obesity, gray areas for sexual medicine, gray area for some of the urinary, female urology, female urinary problem. So these are some various aspects where the gray areas where it can serve the purpose for that. Lastly, the medico-legal scenario is always keeping us really afraid of what we are very afraid and we are skeptical about it. Every time we do a decision or a practice, we apply for a defensive obstetrics and gynecological practice. But believe me, if you do not have a malified intention, God is there to help you. Nothing will happen. You have to take risk for that. And for that medico-legal aspects, you have to know these few C's. I must tell you, competence, important is a competence. You must be very competent enough and you acquire a skill to become competent for that. A good communication skill is important and a building up of the rapport is important for the patient for that. A counseling, people do not have a time to counsel now with the busy practice. Counseling. The next is a case records. You spend some time or ask your junior to take in case records, detailed case records. Case handling. The case handling becomes very problem if you find a bad people or a bad advocate giving rise to that, and therefore you have to select an advocate who is a good thing for that and consult the medical legal experts for that who can deal with that. Consumer and criminal laws. You must know basic about the consumer and criminal laws. Now there are various laws which have been there, and PCPNDT, MTP, and now the ART. These are the three important laws one should be very familiar. All gynecologists and obstetricians should be familiar with that. And at last, the community and society support should be there also, because we need people. We are one party into it. The community and society should fight for us. Then medical legal aspects will be solved for that. Now, coming to the second important aspect of logi of gynecology. The logi of gynecology, what are the changing trends in gynecology? Is a more of endoscopy surgeon and ART physicians than the general gynecologist. Which alluring subject is endoscopic surgery, alluring subject is ART physician for that. But abuse of endoscopy and ART there. But use it, don't abuse this particular balance for that. Minimal invasive surgery is increasing. Trends I've already told, from guesswork diagnosis to definite diagnosis, from indicated surgery to unindicated interventions. I have told one incidence of about the increased prevalence of cesarean section. Unindicated hysterectomy is also one other part which unindicated surgery is a very important determinant and a risk and unethical thing for the obstetricians and gynecologists. From 2 fingers in the vagina to 2 eyes in the pelvis, I have already told about it. From autologous native tissue to mesh and prosthesis. Once upon a time, for 2 decades, the mesh has ruled the world. And I remember when there is a controversy, I have a debate with the mesh people that I believe in autologous native tissue, then mesh and prosthesis for that. Gone are the days where peri-G, apo-G, and all this mesh plastic was done in that. I think it has almost gone to the graveyard. Now mesh has become a mess, excepting the TOT mesh. The TOT mesh has become very important part for that, and for hernia, this has to be used for that. Otherwise, rest all cases, autologous tissue has to be used for that. Pharma augmented therapy. Many people we have been pressurized or being influenced by the pharma people and pharma augmented therapy, so that we do certain irrelevant things for that and unethical things for that. Gadget oriented surgeries again, when your only tool is a hammer, everything will look like a nail, and therefore if I have got an endoscope or a laparoscope, I will do all cases with a laparoscopy. That's not the good science and the evidence-based science or the rationality in that. Teleconsultation and telesurgery, there are merits of it, but demerits of it also. As far as our subject of obstetrics and gynecology is concerned, as far as our emergency is concerned, I think teleconsultation can be restricted to few areas where a subsequent follow-up is necessary, but telesurgery is yet to be defined and yet to be practiced over the globe. That needs a lot of innovations for that. From decision to dissection, we are very good in dissection, but very poor in decision. I think a surgeon should be equally good in decision and dissection, and then they can be designated as a surgeon. Otherwise, she should be designated as a technician and a craftsman for that. These are some of the focused areas in gynecology. Adolescent gynecology, infertility and pregnancy loss, menstrual disorders, preventive gynecology and screening, newer contraception and medical abortion, endoscopy and its spectrum, imaging sciences for that. They are already part of this, I have told you, but these are all focused areas in gynecology where our next gen can devote attention to this particular aspect for that. Operative gynecology, there is a changing trends, as I have already told. Urogynecology and female urology has evolved. Gynecologist is separate subspecialty, and credentialing and certification is also there. The MCH in gynecologist has been established in countries like India. Organ preservation and conservative surgery is the norm today. Gone are the terms of radicality except in the malignancy, but organ preservation and conservative surgery. Need for new molecules, which I wanted, the gray area where I invite the researchers, I invite the pharma people to go for the new molecules. There is a need for it. Midlife management we're ignoring. Psychosocial issues and end stage management is also an important part, which our gynecologists, we should take it, because we are the category of the people who cater these services from creation to cremation. and therefore from the birth till death, our field is so much vast that it should not be neglected for that. Now, a little bit about the gynecological surgery. Gynecologist, in the past it was a history, but the present was a jittery, and future was a mystery. We do not know where we are heading for that. And the past, the concept was cut and see. The present, see and cut. And the future, one will see and another will cut. I will see in Cuttack and you will cut in Mumbai for that. And when telesurgery will come out, this will prove really a work for that. Expanding horizons. Only one is left to future in obstetrics and gynecology. Delivering, can you deliver a baby by a scope? Everything you can do it. But by a scope you can deliver it. Is it possible? Yes, is it possible? Why? Because in future it could be there. The concept of laparoscopy came from a mythology of Arjuns, and seeing the reflection in the water, firing for that. Same thing can Indian mythology, the Hanuman, the Mahabir, the theory of minimizing and maximizing. You can small size and can be big size. You enchant a mantra, the fetus will be small, 3 kg will be converted to 3 millimeter, and you suck it through the hysteroscope, and then after 3 millimeter, you enchant a mantra, 3 millimeter can be a 3 kg baby and hand over to the couple for that. This could be possible in future. This is a fanatic idea and an idiotic idea for that, I believe, I'm sure, but it might come true for that. Now, status of technologies and techniques. The OR setup, operation setup has become really a drastic change. Instruments and gadgets, there is no limit. Procedures, there is no limit for that. Robotics and telesurgery. And at last, I am emphasizing that artificial intelligence will again help in that. From crowd to calm and lonely OT, hidden instruments will be there. Very few people or no people in OT, no cables, no tubes. Automated camera movements, voice activated universal control, remote control robotics and telesurgery will be in the norm in future for that. So future OR setup will be like this, a calm and lonely OT setup. Future emerging techniques like robotics, single lobe surgery, single node laparoscopic surgery, nodes, trochanless laparoscopy, endo barriers for that. And implications of the development of art and science surgery revolves around advances in robotics, virtual reality, digitalization, simulation for training and teaching is a part and parcel. And last but not least, everything boils down to artificial intelligence for that also. As a teacher, as a teaching and training of surgery, I say it will take me 1 year to teach the trainee how to do surgery. It will take me 5 years to teach the trainee when to do surgery. It will take me lifetime to teach the trainee when not to do surgery. This is a Professor Smith quotation, past president of RCOG. What is the future of MIS? What next? Minimal invasive surgery has all the content to flourish in 21st century. The day is not far when MIS shall be performed by machine with artificial intelligence, which may even have the faculty of digitalized clinical judgment. However, surgeons' conscience and intuition can never be digitalized. That shall be the only difference in human and robot surgeons for that. Now, what is happening to the future generational patients? Adults in the office are from home, infinite amount of time. They want instant diagnosis. They want immediate treatment. They don't want any complications. Pleasurable surgery and lives with 200% cure. That is only possible when we physician and surgeons will be a superhero and miracle healer. When this will come, all this can be met with that. Future is the age of information. The fundamental change from tissue to instruments to information and energy, from objects and atoms to bits and bytes, from macro to nano, and from knife to chip. And Sir Robert Hutchinson told, from the inability to let well alone, from too much zeal for the new and contempt for what is old, from putting knowledge before wisdom, science before art, and cleverness before common sense, treating patients as cases, from making the cure of the disease more grievous than endurance of the same. Good Lord, deliver us. Coming to the human reproduction, changing concept, from hopelessness to hopefulness, from natural to manipulative, from prayer to science, from bedroom to laboratory, from sexual to asexual, from conventional family to unconventional family, and from man to superman. the future of human reproduction. Since the designer babies, the reproductive cloning, reproductive bazaar, non-sexual reproduction, and artificial womb. That could be the future for that. And in this connection, Albert Einstein quotation, I fear the day that technology will surpass our human interaction, the world will have a generation of idiots. And this is what Einstein has expressed. The Charles Dickens statement told, the 21st century is the best of times if one considers the so-called scientific developments, and the worst of times when one critically looks at human developments. We are all human beings, and obstetricians and gynecologists, as I have already told, they believe in amalgamation of head, heart, and hand. And I feel that proportionately we grow. I want that the next gen should be both ways, scientific development as well as human development go parallel and hand to hand for that. Now, the second component, ladies and gentlemen and my viewers, second component has been given. This has been given by the team Juventus to say a few words how to be successful professional for that. And that's why I'm including key to be a successful professional. Now, first question, ask yourself, you want to be a man of success or a man of value? Everybody will say, I want a man of success and value. So it's a both I want it for that. And there are some tips and tricks how to make it for that. So key to be successful professional, the basic foundation. You imagine yourself during your postgraduate training where you lacked. And then the postgraduate training is a basic foundation for professional for that. For that, the institute is responsible for that. Institute, the alma mater, is responsible for giving you a training. And faculty and mentors are responsible for giving a training. And a good faculty and mentors are really essential for a successful professional for that. Apart from it, the individual effort of sincerity, the hard work and dedication during these 3 years of post-graduation is absolutely rewarding and paid in next 30 years onwards for that. That is, I'm sure that these 3 years of basic foundation, if you have a strong foundation, I think 30 years in the practice, you can be a good professional for that. And with the amount of the training, with the number of postgraduate increasing nowadays, with the centers which is there for that, I think the post-PG training and experience are an important component to add values into your training for 3 years. So senior residentship and working under a good guide is important after post-graduation. During the post-graduation, there are some limitations of the only aim is to get a degree for that. And don't think that the only aim is to get degree, but the examination every day will face after that. One examination in MD is not enough. After that, every day you will face examination before the examiners are the patients of yourself for that. And therefore, post-PG training and experience are important. And senior residentship and working under a good guide, you should can deliver the goods for that. Now comes decision for future. There are various people of a decision of various future. Temperament is different. Some ambitions are different. And to be general gynecologist and obstetricians, there are majority who enter into general obstetrician and gynecologist. Now selecting a subspecialty. I have told that innumerable subspecialty has evolved in gynecology, like an endoscopy, like a gynecological oncology, or human reproduction, the fetal medicine, high risk obstetrics. There are a number of subspecialty and evolving specialty which is very good for that. And there are some people who wants to go subspecialization for that. That's all right. If you mentally prepare yourself that this specialty is alluring for you, you devote whole time for the whole of the career for that. You can do a tremendous work. You can do a lot of improved work for that also, subspecialty. Training in different subspecialties. Many people want that I will be a general obstetrician and gynecologist. Those who want a general obstetrician and gynecologist, I will advise you to have because the growing subspecialty is so much, you should have some training in different subspecialties. You should be a good sonographer. You should be a good endoscopist. You should be apt with the fetal medicine. And these little training is important in different subspecialty, varying on amounts of days from months to years. You can do a training and short training in various aspects and devote into general gynecological practice. So sonography and endoscopy, I believe that these are two arms of the professionals. Without the knowledge of sonography, you cannot be a good complete obstetrician. Without the knowledge of endoscopy, you cannot be a complete gynecologist. Then some of you might come as a teacher. They decide to be, they have an ambition to become a teacher. I think this is also wanted because there is a dearth of teachers and all that. You decide yourself to become a teacher from the beginning for that. And many people enter into government service, public sectors, private sectors, and there are some family or spouse influence. Depending on the spouse also you change even if you don't want it. Depending on the family need also you change. You have to stick to that family and you have a responsibility of the family and spouse. The need is there for that. And there are some people who wants to go abroad, settling abroad for that. Now, of course, earlier it was too much. Many people have aspirations to go abroad, ambition to go abroad when we were students for that. Now, I think settling in your own place and Atmanirbhar Bharat and Bharat India is India. I think you can get a lot of good things in India and you can repent after going abroad after a few years why you have come back for that. And there are very few persons who change a profession also. They left the profession after practicing or before practicing also. I have seen people entering into the pharma business. They have come a company, doctors have become a company. You see the corporate hospital of Apollo, they have started from the beginning for that also. Or some people entering into the politics and become leaders and the social activists for that also. So you can do it, choice is yours for that. Basic need for a successful professional. What are the needs? How you do? These are the tips and tricks. What are the needs? Adequate knowledge. You should have an adequate knowledge of that particular subject. You should have a very good. Now there is no dearth of information. When you see about a decades before, there was a dearth of information. In our place, when we were students, the knowledge was very limited. There were half of Almira, only half is filled with the Gynaecology and Obstetrics book in the library. Now, adequate knowledge is there. You can get information from various sources. The internet and the Google has provided a lot of information. Anything you with the fingertip, you can go it for that. And individually, you should have a will to acquire that. Will and skill is important. These are two important things. The skill, when you acquire a skill, everything will follow. The only very important aspect of the professional is a skill. So if you acquire a skill, everything will follow you. And for that, you will have a strong willpower to acquire a skill for that. And there are a lot of methods for acquiring a skill. We are doing a lot of workshops, this webinar, the workshops, the conference, the journals, the surgical accompaniment, the surgical guru and surgical training. This will enhance your skill. Try to develop, and there is no age bar for development, age bar for acquiring a skill for that. You acquire a skill till the last breath. I am also acquiring till today also. I am really acquiring a lot of skill. I feel that I am a student. I know only 0.1 fraction of a subject of my subject. 0.001% I know of obstetrics and gynecology for that. And sincerity, hard work, these are all part and parcel of personal development you do it. Patience, you must be patient. Communication, again, I have told about the communication, the good communication with the patient so that you can influence the patient. A humor with the patient, talking to the patient, the humor can really build up the confidence and rapport to the patient for that. So building up of the rapport deals with this communication. This cannot be by telecommunication for that. Telecommunication cannot do it, and the WhatsApp cannot do it. The confidence, the expectation effect, face-to-face contact, and the talks, and this has a tremendous impact not only in building rapport but for the relief of symptoms and the cure of the disease of. And remember, many people say need of the patient rather than the mood of yourself. It's the patient's need is a priority. You don't think that I will attend the patient as per my need, my mood. That will not be a successful thing for that. So the need of the patient is a priority. If you give it, need of the patient is a priority. And if you see what is the need, the patient tells about the history that I have some problem. Why she has come to you? She wants that problem. She has come with a problem. You target and think of solving the problem. That is the end result for that. And if you want to solve the problem, you are a successful professional. And a lot of you think about various theories, various literatures and all that, and forgetting about the line of management, then you are gone. Ultimately, a patient has a problem, you have to solve it. The end result is important. The end result, if it's good, you are a successful professional in that part for that. Apart from it, your personal development you must develop in a certain aspect. For example, I'm giving 4 important aspects you control yourself. Anger, you control your anger. You control your ego. You control your complex. You control your envy. Don't compare with other persons that he is a superior. He knows laparoscopy much better. I am in the periphery. I'm not doing it. That's bad. Periphery, you are doing a good service for that. Don't compare that you are doing less work for that. I think complex should not have it. Don't have a superiority complex. Don't have an inferiority complex. Have a confidence in itself. Confidence is very, very important. Don't envy on others. If somebody is doing well, don't envy on others. Go and make a friends with them. And this is a very important thing for a professional thing. Professional fellowship is very, very important. And don't comment on some other people that he is doing like that and all that. So these are all personal development which I will tell that it will not only help you, help your society, help your profession, help your subject as a gynecologist for that. Interpersonal relationships, this is very important. Interpersonal relationship, you do your internal inner engineering to develop yourselves, but the outer thing, interpersonal relationship with the colleagues, how you deal with the seniors and juniors, with other disciplines, with the pharma people, these are all important things. Paramedical and other medical staffs around, these are all an interpersonal relationship you should maintain for that. And risk screening and action. When a case comes and you identify and risk screening, don't refer always that everything you refer it. You don't take any risk, no gain. You try to solve it at your own level, and if necessary, and ask somebody, take help of other people, take risk, no gain. Charity, I think this is a part and parcel, and I believe that I'm proud of my obstetricians and gynecologists. They are the leaders in charity in contrast to other faculties of medicine. Don't run after money. Money should run after you. Take it. This is a Bible. Don't run after money. Money should run after you. You think you contact that, and I think it's 100% true for that also. And I practiced it, and I preach all my students for that. Tips and tricks of medical legal eventualities. I've already told about the different C's and tech for that. Tips and tricks. And remember, again I'm telling you, if you don't have a malified intention, God is going to help you. Forget about all these medical legal cases. You are being saved. God is above you for that. And you have a personal life as well as a professional life also. And apart from few people, I can quote, few people do not have a personal life, individual life, but have not a family, but still have a personal life for that. So work and personal life balance should be there for that. It doesn't mean that you have a family. Even you doesn't have a family, you have a personal life. You have to work and life balance should be there for the health of yourselves, for the benefit of your family, for the benefit of your sons, daughters, wife, and your parents for that. And work and life balance is an important part. Sometime we'll discuss about this for hours together. It will take for that. And lastly, introspection. You always think about it. Nobody thinks whether introspection. You make a week of a few times, 15 minutes of thinking in 1 week. You take it. Personal introspection and professional introspection. What wrong I have done it, just think about it. And don't think about what right I have done it. What wrong I have done it during the last 1 week, and automatically right thing will come forward in the subsequent thing for that. So introspection is a very important thing for that. So, ladies and gentlemen, there are 2 determinants of success: strong commitment and willpower, and divine's blessing for that. And these are the 2 things which can make you successful professional, a man of success and man of values for that. Thank you, ladies and gentlemen, and my viewers, for giving me this opportunity in the second series of Solving Clinical Dilemmas. Thanks the Juventus team for organizing and rejuvenating every one of us for that. Thank you.
Thank you very much, sir, for this very informative lecture and inspiring lecture. Sir, there are so many admiring messages and questions also. If you permit, we can take few questions, sir.
Yeah.
Sir, there is a question from Dr. Sushmita Mishra. She is asking that, is quadruple marker a must in all cases?
I think quadruple marker, we are always initially if we focus for the biochemical test, the 11 to 13 weeks scan when we are doing an NT, at that time double marker has to be done. Now, if double marker has the limitations for that, if it is not coinciding with the CRL, you cannot do a double marker for that. So, or some cases you are missing the double marker, the quadruple marker can be a substitute for that. So, that is the only thing for that.
Okay, sir. Sir, Dr. Suresh Chandra Mahapatra, he is thanking you for this wonderful, uh, good initiative in the direction of knowledge of proliferation and profusion. So he is thanking you,
Thank
sir.
you. Thank you.
So that's all, sir.
Thank you.
Okay. Thank you, sir. Thank you very much.
Thank you very much. I hope the audio
Thank,
video is
thank you very much, sir. Thank you very much.
Rachel
Nilesh.
ma'am,
Thank you,
audio
sir.
stop, video stop कीजिए.
Audio video is absolutely all right, Gusali.
Yes, yes,
Yes,
sir.
yes, absolutely
Yes,
clear,
sir.
sir.
Everything.
All
Yes, sir.
throughout, it was
At,
very clear.
at the
I find that there is a time lag. So that when I see here one and already this is not being there, and after 1 minute it comes.
Few seconds delay.
yes,
So
yes,
that
sir.
so that may be because you are speaking, but for the viewers, it is continuous, sir.
Then I'm very happy.
Yes.
Thank you, IT team, for
Thank
doing
you,
all
sir.
this
Thank
for
you very much.
me, and thank you the team
Thank you.
Juventus for doing
Thank
that.
you, sir.
And
Thank you,
Thank
sir.
you
thank you,
very much,
Diwan.
sir.
Diwan is also there, and Diwan, Sanjay, Nilesh,
Yes, sir. Yes, sir.
Brushali, and the
Thank
whole IT team. I congratulate and I thank. And last but not the least, my assistants Akshay and your
Uh,
favorite Dev.
you.
so many
Yes.
doctors are thanking you for resuming this webinar series, sir.
Thank you, thank you,
Exactly, sir. Thank you very much for restarting this. It was the
Uh,
most awaited one, sir.
thank you.
Thank you,
Thank you, sir.
sir.
thank you.
Chalo, doctor sir.
Oh,
Bye,
Dr.
sir.
Saib,
Bye.
chala.
Bye, ma'am.
Oh, bye, bye.